Okay, acute coronary syndromes. I think the best way to think about acute coronary syndromes is, acute coronary syndromes, think about them as being on a continuum. So if you think about the patient having an acute coronary syndrome and this being on a continuum, where we start out over here with atherosclerosis, stable angina, unstable angina, myocardial infarction. So it's a continuum of a problem, rather than it being just black and white, like rule out MI, rule in MI, kind of a thing. So that's how we used to look at it. It's just simply the patient ruled in or ruled out for an MI, and that was all there was to it. But now we realize there's more to it than that. And in fact, that our patient has this continuum of process that's occurring as the result of atherosclerotic disease. So we start out over here with just a little bit of atherosclerosis. We move into stable angina, where the patient has chest pain, shortness of breath, diaphoresis. You know, maybe the patient walks up a flight of stairs and gets these symptoms. Well, all they have to do is sit down, rest, or take a nitroglycerin, and they start to feel better. Okay, that's stable angina. The next level up is unstable angina. Now, this patient's getting worse. We're further down a continuum, we're getting worse. The patient's got unstable angina. Now your patient walks up a flight of stairs, gets chest pain, short of breath, diaphoresis, sits down and rests, maybe even takes that nitroglycerin, but the pain doesn't go away. The pain doesn't go away. So this patient has to come into the emergency room and have those cardiac enzymes done and EKGs done so we can tell it's unstable angina. The next level down is into myocardial infarction, and we can even split the myocardial infarction up into a couple different pieces. We can call it a ST segment elevation MI, STEMI, or a non-ST segment elevation MI, which is NSTEMI. And basically all that refers to is, are there EKG changes or are there not EKG changes associated with this MI? So if there's no EKG changes, then how do we know it's an MI? Because of the enzymes. Okay, so we got elevated enzymes, but no ST segment, no EKG changes. We call that a non-ST segment elevation MI. By the way, that's the same as your Q-wave, non-Q-wave MIs?
So your Q-wave is an ST segment elevation?
Exactly. Your Q-wave MI is the same thing as an ST segment elevation MI. Your non-Q-wave MI is the same thing as a non-ST segment elevation MI. What it means is basically we got EKG changes or we don't. And if we have EKG changes, that's indicating a more severe injury to the heart, creating more of a problem, a bigger area that's involved. Therefore, that's why we're getting those conduction disturbances, those EKG changes that are occurring. So again, think about your acute coronary syndrome as being on a continuum from atherosclerotic disease all the way working through to the patient having the myocardial infarction. And again, some of the ways we're going to diagnose this is we're going to look at the patient's EKG, we're going to look at the enzymes, 3 in particular, myoglobin, troponin, and CPKMB. Myoglobin is helpful because it elevates early. Myoglobin, though, is also released from the liver and skeletal muscle cells, so it's not very specific to myocardial injury. Troponin is specific to the heart. And troponin is released when the heart just becomes injured. So troponin can be released and can be elevated when your patient has unstable angina or non-ST segment elevation MI. So it starts coming out earlier than CPKMB. CPKMB only comes out when we have necrotic damage to the heart, which means myocardial infarction.